So I think, and again, the sessions today support that there's been a seismic shift in prostate cancer management over recent years. If we look at our seismograph, we see that, we know that PSA screening's gone down. It's led to less incident prostate cancer, less low-risk disease, more advanced disease, and a number of studies support those statements. There's been a real rise in active surveillance, especially for low-risk disease. There's been a rise in surgery for high-risk disease. And that's led to more postoperative indications. I think for most of us as GU radiation oncologists, probably a good 50%, if not for some, much higher than 50% of the practice is postoperative. And there's been an explosion of radiation options, hypofractionation, brachytherapy, LDR, HDR, proton therapy. It's really exploded. This data just shows that, yes, there has been decreasing low-risk disease and increasing metastatic disease or advanced disease in recent years. And I've seen that in my practice, and I bet you many of you have as well. I think part of that was due to changes in recommendations regarding PSA screening. If we look at high-risk disease in particular, the dark gray bars show surgery. Over the years, surgery has been rising, and the use of external beam radiation has been declining. And around 2011 is the first time that, or 2010 is around the first time that surgery overtook external beam radiation, nationally speaking. This is NCDB data for primary management of high-risk disease. So, does bias trump evidence in high-risk disease? This is a study that asked urologists and radiation oncologists, is upfront surgery with the use of postoperative radiation if needed superior to upfront radiation and hormone therapy plus or minus local salvage? Kind of along the lines of the questions we were asking earlier today. So if you asked urologists, the darker bars, they would say, yes, surgery's better, more of the time. Radiation oncologists were a little bit more modest, I guess, at least in this survey, and said, no, they were equal, and some saying, no, radiation was better. Again, I think that goes along with what Dr. Morgenthaler is saying. A lot of this is our own biases that we bring to practice and not necessarily all evidence-based. If we look at the NCCN Guidelines for what is supported in the treatment of high or very high-risk prostate cancer, this is the new guidelines. External beam radiation plus ADT is category 1. External beam plus brachytherapy plus hormone therapy is category, category 1 is referring to the support for ADT, not the RT components. And surgery with pelvic lymph node dissection is also supported. So any of these three approaches, which we've been talking about this morning, are supported for high or very high risk prostate cancer. In this talk, we're going to sort of focus on large studies, largely randomized phase 3 trials, which I've grouped here in the high risk locally advanced column. And we'll touch on a few of these. And I'll make 6 points regarding kind of where we are with external beam radiation today. The first point is, I think, well accepted by this audience, is that you need radiation in addition to hormone therapy. There are at least 2 trials that have compared ADT alone versus ADT and radiation in high-risk locally advanced disease. We do not have the same data in the surgical literature. Surgery has never compared itself to another bona fide treatment in high-risk disease. Radiation has. It's tested itself against ADT alone, and these are the 2 of those large studies showing very clear survival gains by the addition of radiation to hormone therapy. So I think we can unequivocally say that radiation, or local therapy, you can expand that, but at least according to these trials, radiation is needed in addition to hormone therapy. This was good. This was a phew moment for our field when these trials were coming out, not that long ago. Number 2 is hormone therapy is needed in addition to radiation. And the optimal duration is up for some debate, but generally if local control radiation is good enough, you don't need it. If risk of local failure is higher, you probably want it as a shorter course, and if the risk of distant disease is higher, you probably want it as a longer course. And here I'm just going to summarize in one slide one of the most evaluated questions in prostate cancer, which is the addition of hormone therapy to radiation, which has had a host of large randomized international trials that are listed here. Again, hormones alone are inadequate without radiation. I just showed you those two studies. 3 to 6 months of hormones is better than 0. There's a few studies here that many of us will recognize. 3 years is better than no hormone therapy. These are like the BOLA trials and some old RTOG studies. 28 months is better than 4 months. There's RTOG 9202 and a DART study. And 36 months, 3 years, is better than 6 months, another ERTC trial. So what did this tell us? You need radiation, you need hormones, and generally speaking, longer hormonal therapy is better than shorter. That's been the take home. We also have a recent new study from PCS4, Canadian study, suggesting that 18 months may be as good as 36 months. And that was published in European Urology last year. That trial is listed here. It was high-risk disease, 36 months versus 18 months. And this was dose-escalated radiation. And the trial overall suggested that 18 months was as good as 36. But if you look carefully at that paper, I'm just going to make one point about this. Their actual primary endpoint was 5-year overall survival. Okay? And that's right here. And look, those curves are separated, and that p-value is 0.07. And many argue that this study was not powered for that endpoint at that time point. But those curves you can see from 4 years through 8 years have separated somewhat, and some would suggest are trending towards significance for benefit of 36 months over 18. The study was a superiority trial. Okay? But it certainly comes together by 10 years. And so overall, the take-home message of this was, well, it's as good. But I think the details are certainly debatable on that. So again, longer seems to be better. And I think we really need randomized data in the era of combination beam brachy, right? And I think that was discussed nicely this morning. But certainly, the data to date with external beam suggests longer is better. This study, how many have seen this study? This is the NRG RTOG 0521. It was just published in March in JCO, okay? 612 patients, median follow-ups almost 6 years. Look at this. This is overall survival here. It's cut off there. Overall survival advantage to adding docetaxel chemotherapy to external beam radiation and hormone therapy. A 4-year difference of 93 versus 89%, which was significant. And you can see the hazard ratio there. There was a distant METS benefit, and there was a disease-free survival benefit to adding docetaxel chemotherapy in high-risk prostate cancer. Okay? So this opens up all kinds of issues. Should we now start giving chemotherapy in addition to? I mean, we've been talking this morning about doing combo beam brachy and maybe shorter courses of ADT, hopefully. But this certainly opens up further discussion points. So that's sort of the systemic piece with radiation and updates along those lines. Here is the discussion of dose escalation. And it sort of, again, mirrors, I think, some of the discussion this morning. Here's a bunch of the external beam, or largely external beam radiation trials looking at dose escalation. The biggest being RTOG 0126 that was published last year. 1,500 patients. That was the only one that was powered to measure an overall survival difference if it were to exist. And again, this was 79.2 versus 70.2 in largely intermediate risk disease. But as you can see, the trials here span the risk groups in general. And long story short, none of these studies have shown an overall survival advantage to dose escalation with external beam. They all show about a 15% or so benefit in terms of freedom from biochemical failure. They all consistently show that, but none of them have shown an overall survival benefit. And then, of course, there's the ASCENDE-RT trial, and I'll go over these slides quickly because they've basically been presented by other speakers today, but this was comparing dose-escalated radiation, 78 gray, to combo, 46 gray, with an LDR brachytherapy boost, suggesting real benefit in biochemical progression-free survival. I mean, really big. But this did not translate, again, into overall survival. No radiation-based dose escalation trial has actually proven overall survival advantage, including randomized data in the combo space. And we've gone over this potential worse urinary toxicity, both acutely, grade 2, and late GU toxicity, grade 2, grade 3. I think this was nicely addressed by Dr. Zalewski and other speakers this morning. There was an increased need for late catheterization in the combo arm versus external beam. So real urinary toxicities, but as we've heard, well, maybe, you know, I mean, certainly the practitioners of this need to do a good job. And we need to make sure that patients that are getting combo therapy are going to practitioners that do this a lot and do a good job. And as we've heard, maybe even the Canadian investigators who participate in this have less toxicity these days. This was a commentary in JCO by Dan Spratt, Peter Carroll, that basically asked, so external beam plus hormone therapy, which we've kind of gone over the data now in this talk, versus combo with or without hormone therapy, how do they compare? And what these authors argued is there was no benefit in distant Mets, cause-specific survival, or overall survival to combo therapy compared to external beam radiation with hormone therapy. And they argued that in general, these trials that have tried to look at this question have suggested higher toxicity rates for combo therapy. So I think my point in showing this slide is we need randomized data to strongly, that hopefully shows more meaningful endpoints than just biochemical benefit. And I think we also need to focus on addressing some of the toxicity concerns. And certainly if we can shorten the duration of ADT when doing combo therapy, that takes away some of those toxicity concerns that would be associated with ADT. These are questions that we've, I think, addressed largely in the earlier session as to whether or not brachy-boost can allow for de-escalation of systemic therapy with shorter hormone therapy durations. So I'll just skip over this because I think we had a nice discussion on this earlier this morning. There are population-based studies here that suggest here external beam combo therapy is better than external beam in a couple of different studies. And these were overall survival benefits. But again, this is coming from, caution is needed. This is coming from large database analyses, typically SEER or NCDB, that are fraught with confounding, selection bias, misclassification issues. If you're looking at overall survival in these large databases, do you really think that at 2-3 years the curves are really going to separate in terms of overall survival? I would argue that in general, patients who had worse comorbidities, were older, weren't good brachytherapy candidates, had more advanced T-stage disease and weren't thought to be good brachytherapy candidates, were the ones getting external beam alone, and they were more likely to do worse with the endpoint of overall survival. As we've shown, even the ASCENDE-RT trial has not shown overall survival benefit yet with 10 years of follow-up. So I think we need data from the randomized world to further inform population-based studies such as this. The summary on dose escalation then would be that evidence supports in general dose escalation, including combined beam brachy in prostate cancer to improve cancer control, though as of yet it hasn't proven overall survival equivocally. We need to continue to address toxicity concerns and improve patient selection. Some of the issues I was getting to earlier in terms of using imaging and biomarkers maybe can help us with that. ASCO guidelines do tell us, I was part of this panel, that for patients with high-risk prostate cancer receiving external beam and androgen deprivation therapy, brachytherapy boost should be offered to eligible patients. So that comes from ASCO as well. I think in terms of addressing ADT duration, again, I think we need some more randomized data to say, can we safely de-escalate systemic therapy? I actually have some slides that are rather similar to what Michael Zalewski showed earlier in terms of a dominant intraprostatic lesion. So as we were talking about dose escalation and also focusing on external beam, can we bring higher doses to perhaps an MRI-defined dominant lesion? And so this is a paper that Dr. Zalewski showed earlier, but if we can see the lesion on MRI, and here it is after external beam radiation, and here it is after a salvage prostatectomy. Should we not have brought higher doses to this lesion initially? And I'll show this study that just because I like the name, Blastum. This is from Miami that's using hypofractionation or a stereotactic boost, so defining the lesion on MRI, and then in this case using a stereotactic external beam delivered boost. This obviously could be done with brachytherapy as well, or other forms of focal therapies. But I think this is where we're going in the world of external, in the world of dose escalation. Okay, so the fourth topic is also brought up earlier today. Well, is surgery or radiation better for high-risk disease? Which should we do? We don't have a randomized trial. We have the PROTECT trial that looked at intermediate-risk prostate cancer, low and intermediate-risk prostate cancer, suggesting that radiation and surgery are equally good, but we don't have that in high-risk disease. This comes from the PROTECT trial, and this is not known by many folks. Not many folks have seen this paper. If you remember the PROTECT trial from the UK, it was embedded in a large screening trial, right? So there was this CAP trial that was published last year. Within that, case-detected low intermediate risk patients that had a biopsy proving that were brought into the PROTECT trial and then randomized to surveillance, surgery, or radiation. But what happened to those patients that were case-detected high-risk disease? They were not eligible for randomization in PROTECT, so they followed them. They didn't randomize them, they followed them. But those patients either got surgery or radiation and hormone therapy. So this is more like a registry, but a prospective registry that followed these patients. And here are the results from that. This was published in European Urology. Prostatectomy in red, radiation in blue. Hormone therapy, as we saw earlier in my talk, is not good enough. You need hormone therapy. This supports those other trials I showed you earlier. But in terms of local therapy with surgery or radiation in high-risk disease, this is pretty good data. And yes, not randomized, but from a randomized general framework. So again, I think we're pretty well positioned to say that either approach would have, we expect, similar oncologic outcomes. And yes, we've seen the Keyshawn paper in Gleason 9-10 disease suggesting that combo beam brachy was better than external beam and prostatectomy. First of all, this shows external beam and prostatectomy are equally good, again, in Gleason 9-10 disease. That shows us, but it's provocatively suggesting that combo therapy is better. But it's better in terms of overall survival, met-free survival, prostate cancer. Do we believe that? I'm just asking that to ponder. Why should the combination of beam and brachy decrease risk of METs compared to surgery, where surgery could have been followed by postoperative radiation and hormone therapy as well? Why? Why does it prevent distant MET-free survival compared to actually removing the prostate gland in very high-risk disease? And I think it's just maybe for the discussion period later to get into that in such a substantial way. Clearly, we need randomized trials in this setting again, because selection is always going to be a concern here. Did those that were good candidates for brachy get brachy, and those that had more advanced T-stage disease or other poor selection factors get the other therapies? I'm not saying that that was the case, but that's why we need a randomized trial. So the fifth topic of some controversy is pelvic nodal irradiation, and this is kind of an age-old question in the world of radiation oncology. This was the original reporting of the 9413 trial in JCO in 2002, suggesting that whole pelvis was better than prostate-only radiation. But here was the update of that trial, and those are superimposable lines. And so there's one other randomized trial, if you're not aware, called RTOG from France, RTOG 01 trial, that also tried to look at this question. And again, it was pelvic radiation versus prostate-only radiation. Overall, the trial, no difference, as you can see. If they defined a low-risk group or a high-risk group, and low risk or high risk for having nodal metastases, because it was all generally high risk, no difference. If they changed the endpoint to progression-free survival, no difference. If they changed it to event-free survival, no difference. If they looked at event-free survival in the high-risk group, no difference. Only here, I mean, this is called chopping of endpoints. Only in a group that had a presumed lymph node involvement risk of less than 15%, and I think this was according to the Roche formula, did pelvic radiation in blue do better than prostate only? Kind of counterintuitive. You'd think the higher risk group would do better, but that wasn't the case. It was this group. In the higher risk group, there was no difference. So here we are. What do we think? This is sort of a surgical template as to where positive nodes are found at time of pelvic lymph node dissection with prostatectomy. And the question is, which radiation field do you prefer? A prostate only, a small pelvis, a larger pelvis? I mean, one's tempted to sort of want to cover more, right? And as we saw by the arms go up earlier, a good number of us treat pelvic nodes in high-risk disease, despite 2 negative randomized trials that I just showed you, right? And so why do we do that? Is it because of what Abe brought up, that just somebody told us that we should do it? Maybe, but 2 negative trials. This trial, though, has been going on. Mac Roach, who really believes in pelvic nodal radiation, has been a real champion of it, is the PI of this trial, 0924, which is miraculously over 2,000 patients and is either completed or about to complete accrual very, very soon. It has accrued like gangbusters. As you can see by the stratification of the risk groups, they're trying to address that unfavorable intermediate risk group too. Maybe they're trying to make sure they have enough representation of that, what RTOG was suggesting. If you have a lymph node risk less than 15%, there was a benefit. So I think if this trial with over 2,000 patients is negative across the board, we have our answer. But I think also this trial is best positioned to inform a subgroup that may truly benefit from nodal irradiation. My last brief topic is, well, what about node-positive disease? Again, we've seen that radiation added to hormone therapy improves survival in locally advanced prostate cancer. That goes all back to my point number 1. There's retrospective studies suggesting that there's benefit to adding radiation to hormone therapy in pathologic node-positive disease post-operatively. But there's no successfully completed randomized trial to inform adding radiation to hormone therapy in clinically node-positive disease for those patients that haven't gone to surgery. And that's the truth of the data. This is a study that my group did looking in the NCDB with propensity score matching. Again, nationally, I mean, this is again fraught with all the selection bias that I referred to earlier with other studies, but suggesting a real benefit in terms of overall survival in adding radiation to hormone therapy in node-positive disease, hazard ratio of 0.5. If we look at the STAMPEDE trial from the UK, and we look at a node-positive cohort from there, they also, this was not randomized, but they had patients who got radiation, those who didn't get radiation, and those who got radiation did better. Very similar to the NCDB trial that I just showed you, with a very similar hazard ratio of about 0.5. So it seems like there is, and I think in general we want to be aggressive with those patients, and I think likely appropriately so. So with that, I have these closing thoughts. First of all, combined modality external beam plus longer duration hormone therapy are effective treatment for high-risk locally advanced and node-positive disease, improving survival. That is a statement that we can take to the bank. And there's a lot of randomized data supporting that. What about becoming more intense on the systemic therapy front? Should we add chemotherapy per RTOG 0521, just published a few weeks ago? Should we add abiraterone or enzalutamide or apalutamide or one of those new drugs that Crawford talked about? And I think there are trials that are looking at this. What information should we use to inform that? Can biomarkers help this? How is advanced molecular imaging, PET imaging, changing the landscape of high-risk locally advanced disease? Where now, if we are routinely going to start using PET in staging, not yet approved in upfront staging of high-risk disease, but we know if we start using it there, we're going to find oligometastatic disease quite a bit. How's that going to change what we do in terms of what systemic therapy we add? How aggressive are we going to become with our external beam in terms of addressing sites of oligometastatic disease only detected by PET? Evidence supports dose escalation, including combined beam brachy to improve cancer control, though perhaps not overall survival, and we need to address toxicity and improve patient selection for that, in my opinion, as we talked about earlier. The value of pelvic nodal irradiation in high-risk disease still needs a better answer, and fortunately we have that trial, RTOG 0924, that, with over 2,000 patients that will further inform this. Ultimately, most high-risk disease warrants multimodal therapy. I think that's just very clear. And such patients need to be seen in a multidisciplinary environment to have all of these options presented to them. They need to see the surgeon, they need to see the radiation oncologist, they need to see the medical oncologist as well. So with that, thank you very much for your attention.